atrial fibrillation and flutter in under 10 minutes. Okay, so first let's recall what a normal rhythm looks like. If you remember, we had a P wave representing the atrium contracting. Then we had a QRS, and that was the ventricle contracting. And then the T wave representing the ventricle repolarizing or relaxing. Right. First thing you notice when we look into an aFib or a flutter is that there is a QRS, right? So the ventricle is contracting, but the P wave is kind of a lot of activity taking place there. So the first thing that comes to mind is, where is the atrium contracting and why is there so much activity? Even more so in an A flutter patient, right? Okay, so as far as definition goes, this is not the exact definition, but it truly is what you need to know in regards to the atrial fibrillation, is that you will see an irregularly regular rhythm. You'll see that pop up very often, and it's a very common terminology that's used to represent atrial fibrillation. Next, let's take a look at a cause. Hypoxia is the most common cause, number one cause of atrial fibrillation, and mitral stenosis is not a very common cause, but it is commonly tested to make sure that you know the connection between a mitral stenosis and a atrial fibrillation. And here we'll do a little drawing for mitral stenosis so we understand exactly why. So if here's our simple heart, and if you note the tricuspid valve, if there was an opening here, it's a wide normal opening, but in a mitral stenosis, the opening is very narrow, so that causes more buildup of blood in the left atrium, causing a ballooning. Let's see if I could erase this here. Let's get the red color going. And there's going to be a ballooning of this left atrium, and the larger this atrium is, the harder the left atrium has to work, eventually can lead to something like atrial fibrillation. Three most common things that I see pop up often is, as far as test questions go, is somewhere in there they're mentioning palpitations, and the patient can present like heart failure. You may find an unstable patient with hypotension. Next, let's talk about diagnosis. And really, your gold standard is going to be an EKG. And the EKG, you will see no P wave or no definitive P wave. Okay, so as far as treatment goes, really, whenever you're approaching any patient, the very first question that you should be asking yourself is this patient even stable? And there's really only two answers to that. It's a yes or it's a no. And if the answer is no, then really you're done and we're going to have to shock this patient, right? So a direct current. And if the answer is yes, they are stable, your next question should be, is this patient demonstrating a heart failure presentation? And then again, your answer is yes or no. If the answer is no, then the next question is the rate too fast? Are they in a rapid ventricular rate? And if the answer to this is no, then only thing left to do really is just observe. If the answer to their rate is yes, it's a little bit fast, and the question is, what do we want to use to control the rate? And our two options really is either a calcium channel blocker or beta blockers. And beta blockers really should always be your first go-to. The only time I think of calcium channel blockers is if the patient has a respiratory disease like COPD, in which case beta blockers should be contraindicated for you or at least used with caution. So backtracking here a little bit to yes, they are in heart failure. What is my next step then? Well, I have two options when a patient is in heart failure. Number one is amiodarone, and my next option is digoxin, and I'm just going to put here dig. Digoxin should be the first thing that comes to mind in an aFib patient that's stable but presenting as heart failure. Amiodarone should only really be considered in patients who cannot tolerate digoxin. If the question is asking about clots, your go-to drug should always be warfarin. Something else to consider is what if they want to do an elective direct current? So they want to convert them. The patient's not really tolerating medication well, so we want to convert them. And two things that must be done before you perform an elective direct current is one, you want to perform a TEE, and that's your transesophageal echo, and that's to determine that there are no clots. And then, of course, you want to give the patient a warfarin as empiric treatment. Okay, so next let's look at some buzzwords. And definitely your first thing that should come to mind whenever you hear the term irregularly irregular, right away you should be thinking, this patient may have atrial fibrillation. What is a normal rhythm? 60 to 100. So anything above 100 is rapid, and anything less than 60 is a slow ventricular rate. Additionally, do remember that hypoxia is the most common cause, and questions may often ask you if a clot was to form, what type of problem would it cause? And when you think of aFib, think of arteries as it may cause an arterial emboli. Okay, and lastly, let's take a look at a vignette. A 72-year-old male presents to the ED complaining of acute onset of severe diffuse abdominal pain of 4 hours duration. He states that he has vomited twice since the onset of pain. He is afebrile, and the physical exam is noteworthy for a distended, diffusely tender abdomen with normal active bowel sounds. Medications include omeprazole for GERD, digoxin and warfarin for aFib. The abdominal and chest x-rays show no abnormalities. Which of the following is the most likely diagnosis? Okay, for test taking strategies, if you ever see a severe diffuse out of proportion abdominal pain, first thing that should come to mind is a mesenteric infarct, and that's an occlusion of the mesenteric artery, and that's usually caused from some clot, and aFib is the most likely common cause of that clot, making mesenteric infarction the better answer choice. Thank you.